selectivity is not possible. Because you're just overtaking the cell. So how can you destroy the virus and not destroy the cell? And as we'll see, acyclovir answered that. But then there's the assembly, which involves the virus forming these virion particles and releasing. We've got some drugs there, and we've certainly got cleavage, the maturation that occurs. Once the particles released, you have to have these pre-proteins cleaved to their active formation. And we certainly have drugs here, both of these. So actually what's happened over the years is practically every avenue that could be exploited has been exploited. So when we look at these agents, some topical ones, idoxuridine, trifluridine, they resemble thymidine, incorporated into DNA. It can be used in the topical treatment of the eye, but they're not on your drug list. I don't see them used much. The vidarabine is sort of along the same idea. It was an adenosine analog that acts by inhibiting DNA polymerase, viral DNA polymerase. Here that we really just hardly ever use Darabine. So what is it? This came out in the 80s. It came out around somewhere around 1984. And then it got the Nobel Prize, not the drug, but the makers of it, in 1988. Because what an antiviral drug that isn't toxic. And that was the beauty of it. It had this selectivity that everybody thought was impossible. And if you understand, we're going to spend some time on acyclovir, not a whole lot of time, but at least enough to really kind of think about it a little bit rather than just race through it, because it's the prototype of so many other of the antiviral drugs. In the 90s, all these drugs were coming out for HIV. They were all mimicking acyclovir. I don't mean that in a bad way. They're mimicking acyclovir and going after the HIV virus because acyclovir was so non-toxic. Let's see, ganciclovir is a sister drug, and it's toxic. We'll talk about why. But acyclovir, ganciclovir, they get converted to this active form by phosphorylation. The active form inhibits the DNA polymerase, the viral DNA polymerase. Let's see. Yeah. Acyclovir is one of the least toxic drugs. Ganciclovir, though, causes bone marrow suppression. And it's used for cytomegalovirus. Cytomegalovirus, and of course herpes virus, is what acyclovir is. Let's see. Yeah, cytomegalovirus is a herpes virus, is what I started to say. Acyclovir does not work particularly well for cytomegalovirus. But the problem here, and we'll see how acyclovir works, but cytomegalovirus, it uses a viral phosphotransferase. For activation. And that sounds fine, but humans, normal eukaryotic cells, can also activate it. In non-infected cells can also activate. And that's why it causes neurodepression. You're going to get a good activation of it in the bone marrow cells, and that's cause trouble. That'll become clearer when we talk about acyclovir on the next page. Let's take a look at this. This is the miracle drug. And what we see is that it has to be activated by this viral thymidine kinase. And Some of their enzymes will take over and form, this is the active compound. Well, the human, by the way, in this handout, TK is thymidine kinase. It just keeps coming up so many times. But humans have a low affinity. This molecule, the acyclovir, has a low affinity for human thymidine kinase. Consequently, what we see is there's about a 40 to 100-fold greater concentration of the active acyclovir in infected cells versus non-infected cells. 40 to 100 times greater acyclovir TMP, or just TP, concentration in infected cells. Cells that aren't infected will still form a bit. And therefore, that's a lot of our selectivity. We'll see there's a little bit more to it than that, but that right there is a big key. Compare that to gang cyclovir. The concentration of cyclovir triphosphate, it's only about 10-fold greater. In infected cells. I don't want you to remember these numbers, but that's why it's toxic. You get gang cyclovir up to the concentration you need in a viral infected cells, you will be affecting other cells. Unfortunately, the virus gets resistant to this drug, as great as it is. We'll look at mechanisms, but one of the primary mechanisms is that resistant cells decrease the thymidine kinase. They use other scavenger pathways. Maybe I'll just say resistant strains decrease in the TK. And because of that, the acyclovir, therefore you have decreased acyclovir activation. Okay, assuming the herpes virus has gone ahead and activated this compound, we then have the viral DNA polymerase. And this is real common for these antiviral drugs. You're not going to have competition between, this is the normal analog that will fit in, the deoxyguanosine triphosphate. It'll be competing with the acyclovir. And what happens is that actually slows down, I say competitive inhibition. There'll be a slowing of the DNA polymerase. For one thing, you've diluted the pool. And that polymerase is kind of sloppy, but it'll still be looking for the correct base, and it keeps finding acyclovir. And you've just made it harder to find that. So that's going to slow the DNA polymerase. So you diluted the pool of the nucleotides. So that's one way this drug is going to work. Now, notice the acyclovir here, the area I've drawn. That's where you need a 3' hydroxyl group. See on the deoxyguanosine, we've got that 3' hydroxyl. And that's what we're going to need for the phosphodiester bridge. Well, there is no 3' hydroxyl on our acyclovir. So because of that, when the acyclovir triphosphate gets incorporated, it's going to lead to DNA chain termination. So point number 2 is lack of a 3' hydroxyl leads to chain termination. There's not going to be that there's not going to be a phosphodiester bridge to connect things. One other little wrinkle that occurs, though, and that is that we get this non-functional complex. Maybe I'll draw this down here. Number 3. The acyclovir will tie up. Once it's put in there, the acyclovir will freeze the enzyme. So that viral DNA polymerase is, let's say it's locked up, it's frozen. The idea, though, is it's no longer active. So, great drug. This is why it's selective, because it has to be activated upon by an enzyme that's mainly a viral enzyme. So it's only going to occur in infected cells. Acyclovir, golly, you could rub it on your hands if you wanted to. It's not going to do anything. Gangcyclovir, in the pharmacy, we treat them like an antineoplastic agent, like an alkylating agent, like cyclophosphamide or something. It's you just don't want exposure to it. You got your chemo gloves on, it's in a special bag and all this stuff. Maybe that's overkill, but the point is that's the difference in toxicity between those drugs. Now, frequently with acyclovir and gangcyclovir, a valine is added. And that'll lead to like bowel acyclovir. And it's kind of strange, the bowel acyclovir gets absorbed, and then in the first pass, all of the valine is cut off. Valine is removed in the first pass, which leads to acyclovir. But the reason they do that is the valine added, that'll increase the bioavailability 5-fold. And you have to give a pretty big dose of the acyclovir. And it gets big enough where you can't swallow the bloody tablet. It gets that big. Whereas with the valacyclovir, we give a 1,000 milligram tablet. And the person can get it down. It's one of the bigger tablets that I've seen. But now you get a big dose, and it just leads to a lot easier dosing. It allows us to effectively give a bigger dose. So valacyclovir, valganciclovir, it's the same idea of what they're trying to do there. Just kind of a little point, not nearly as important as all these other points that I brought up on this page. Okay. This is the models we'll see when we look at the HIV drugs. Not every one of them works this way because they come up with so many different ways, but this is the idea. Okay, on to the not so good ones. Amantadine, romantadine, amantadine. Amantadine is also used for Parkinson's disease. That's where you might see it on the boards. It'll block the uncoating of the influenza virus. The thing is, you have to use it within 48 hours after infection, or you can use it prophylactically if somebody's in a nursing home where there's a lot of flu going around. But really, the flu shot is better. So I've no longer asked students to know these. Flu shots aren't perfect, of course. They don't always match the virus up correctly, but you have these different strains, and it's polyvalent, but they don't always catch it. Okay, then we have these drugs that are called the neuraminidase inhibitors. And it's for influenza. It's for the regular flu. But this attaches to cell via these sialic acid moieties, which are present on many cell surface glycoproteins, and upon upon egress, or when the influenza virus is trying to leave. It's done its replication and now it's getting ready to leave. It's tethered to it's tethering the virions to the cell surface and preventing their release. So the influenza virus encodes an enzyme called neuraminidase, and that cleaves the sialic acid from the membrane, prevents the release of the virus. So you don't have neuraminidase, the virus remains tethered and cannot spread to other cells. Fairly simple idea. I've included some diagrams here. It just shows that what we've got here, the zanamivir and the oseltamivir, these are analogs of sialic acid. And they'll tie up the neuraminidase. So, some notes about these two drugs. They're still quite expensive, particularly the oseltamivir. Zanamivir was the first inhibitor to come on the market, horrible bioavailability, so you have to give it as an inhalation. So it's not nearly as important, but the oseltamivir is given orally. Look at this. These expensive drugs reduce the duration of flu symptoms in patients who are already infected with the virus by 1 day on average. And even that requires that the drug be taken with the onset of symptoms. So really where these drugs are effective is in preventing human mortality from some really severe flu strains like the avian influenza, the bird flu, or the swine flu. Occasionally there's been these epidemics of a pretty, of a strain of the influenza virus that has a high mortality. So save it for that. Oseltamivir, we're even finding out in a small percentage it causes some really strange psychiatric problems while the person is on the medicine. Some people are really saying let's really reserve it. Don't give it for the common flu. So these are really flu strains with a high mortality. Is where you want to use it. Equals the indications is what I'll say. A lot of money was spent on these neuraminidase inhibitors. If you get one of these really nasty flus, yes, they're useful. Other than that, the common flu, still the best thing is the flu shot. Because we know that has problems. It just isn't always matched up because the virus is always changing. Ribavirin, this has become a great drug. It's been kind of, for a long time, just been about as useful as those 4 or 5 lines in the notes here. Inhibits a replication of a wide virus, a lot of viruses. It's a nucleoside analog, like a lot of these antivirals, but it's very useful to Hep C infections, and we'll talk about those later. I've added those on at the end. Okay, foscarnet. Foscarnet's a nasty drug. When the AIDS epidemic was really leading to full-blown AIDS, not just HIV, but the whole disease was getting blown, you're seeing it much more commonly. Foscarnet was used. And talking with people, they just said, they just didn't want to go through it again. It was that toxic. So why would we use it? Well, it's this strange-looking inorganic pyrophosphate analog, inhibitory for all herpes viruses. It'll even work in the herpes virus that's TK negative. So it doesn't depend on that thymidine kinase, in other words. It inhibits nucleic acid synthesis by interacting directly with the polymerases, with the DNA herpes D polymerase or the HIV reverse transcriptase. But it blocks it is a pyrophosphate compound, and what it does is it blocks the pyrophosphate binding site of the viral polymerase. Also inhibits the cleavage of the pyrophosphate from the deoxy nucleotide triphosphates, and therefore no phosphodiester bridge. I think if you know that phoscarnet inhibits DNA polymerase, viral, the HIV reverse transcriptase, and it doesn't require the thymidine kinase, you're doing great. It's a backup to a cyclovir. And I'm not going to worry about the toxicities. It's going to be clear to your information only. I don't see phoscarnet used much anymore, fortunately, because we've got such better HIV drugs. Okay, looking at the big one here, the antiretroviral drugs, the HIV. As we go through these HIV drugs, there's three main groups. There's some odds and ends, some sort of eclectic ones, but there's three main groups. We'll get into what they are, but they can actually push the viral levels down to non-detectable. So, one of the HIV drugs is lamivudine. And a friend of mine, a pharmacist, and a good pharmacist, he accidentally, the doctor wrote correctly for lamivudine, but into the computer he entered lamotrigine, which is a preventing seizure drugs. Interestingly, the doctor was she was a little fireball. She just started screaming one day, what happened to this guy? His viral levels were down to non-detectable, and now they're back up. And finally, she told the patient, bring your medicines in. I want to see every one of them. And she put them in front of my friend and said, here, is this what he's supposed to be taking? And my poor friend looked at it and went, oh my goodness. But these drugs are so good, they were able to push his viral levels back down to non-detectable in a very short time. So they got to the bottom of it. Along with this, we can reverse the CD4 decline. And therefore greatly decrease the infections that occur. One of the problems is compliance, and patients, they go from death's doorstep to all the way back to fully healthy, and their CD4 levels come back up, their viral levels are non-detectable, and they're like, do I really need to take these drugs? I think maybe I'm cured. And it's like, at this point, we can get your viral levels down to non-detectable, but the virus is still hiding out. And stop taking the drugs, it will come back. Okay, look at this little scheme here. It's a nice little scheme that shows you where all the drugs work. Let's see. Yeah, this is an antiretroviral virus, so it's got single-stranded RNA that it's going to use to make DNA from, with the reverse transcriptase. This GP120 and the GP41 that's on the virion particle, that's needed for attachment. Let's see, don't want to get too quick here. I think for attachments to the CD4. You obviously have to have the CD4 receptor there, but there also has to be that chemokine receptor there, because we've got drugs now that block the chemokine receptor, and with that you don't get the binding to the CD4 cell. I'll just write that here. Okay, but assume that everything's intact here and the virus attaches. Then it's going to use its reverse transcriptase. And these things that I'm circulating are quite often where we have drugs that can prevent the action of a particular thing. So in the case of the reverse transcriptase, obviously we've got reverse transcriptase inhibitors. Then we're going to make the DNA from the RNA. Then it has to be integrated into the host enzyme. You've got this piece of viral DNA, and now it's going to have to get inserted into the host enzyme if you're really going to get things to go. And that's what the integrase does. And it will insert the viral DNA. And we've got integrase inhibitors. So assuming the integration occurs like it should, then there's the transcription. We've got some drugs that play around with that, and we've also got viral assembly and budding. Certainly that occurs, but the protease inhibitors become really big, of course, because you can prevent the virus from maturing in the virion particles. So we'll look at each of these a little bit more in detail, but keep in mind the acyclovir motif as we look at this. So, starting off with the dideoxynucleoside analogs, nucleoside reverse transcriptase inhibitors. People like using that little acronym, NRTIs, because we'll see on the next page there's non-nucleoside reverse transcriptase inhibitors, so those are NNRTIs. But it's this group of drugs. These are the mainstay. It's the mainstay of HIV treatment. And they mimic acyclovir. For one thing, I believe that we're looking at zidovudine here. It's not terribly. One of these nucleoside analogs. Notice there's no 3' hydroxyl group. Therefore, we get chain termination once it gets incorporated. Additionally, that is zidovudine shown there. This triphosphate form of base shown here, zidovudine, will compete with the native nucleotides for incorporation. And therefore, it's going to slow the reverse transcriptase. Reverse transcriptase is a sloppy enzyme, but it's still trying to find the right base. It's just not very good at it. And maybe I should point that out. There's some room here. This HIV reverse transcriptase, it's sloppy. Therefore, we have a lot of mutations. But it's very sloppy versus the human DNA polymerase. And sadly, that's one of our main avenues of selectivity here. The human DNA polymerase is very selective, the viral isn't. So these drugs are far more toxic, therefore selective, but it's not as good as acyclovir by any means. Zidovudine was the first one that came out in the early 90s. Roosevelt will put it out. It was the one the FDA was really slow about releasing because they were worried about side effects and the drug trials, and people were going nuts, going, "We're dying out here, and you're worried if the drug is toxic." Okay. Yeah. Additionally, how do I say this correctly? DNA polymerase will be converting this or incorporating it. It is fairly selective, but all cells, infected or not infected, will incorporate some of the false bases. So obviously it's going to happen more often in the CD4 cells because they have the sloppy virus in them. All right. So these are really the two main actions of this compound. So the reverse transcriptase, and once it does get incorporated, you get chain termination. So zidovudine, as I said, was the first one, but a lot of other ones have come out. These all look like Me Too drugs, but they aren't. They give us a lot of nice flexibility. In each of these, there is no 3' hydroxyl group. Therefore, we get chain termination when they get incorporated. One other little point here. If you're reading books and stuff, let's say, well, they're nucleosides and there's a nucleotide, it's like, all right. Yeah, a nucleotide means it already has the phosphate group. So the tenofovir is a nucleotide versus a nucleoside. It just means you skip one of the phosphorylation steps. Not terribly important in this case, but don't waste your time trying to figure out which one is a nucleotide or which one is a nucleoside. Okay, important page. Any questions on that, you guys? Because that really incorporates the acyclovir into these bases, which are the mainstay of HIV therapy. Anyway, is the chat room working? Usually I say hello. Can you guys hear me? Can you hear me? Okay, good. All right, if it's clear, these bases will be converted in all cells to a small degree because the human DNA polymerase isn't perfect, but in the CD4 cells, there'll be a lot more conversion. And that's where we get some selectivity. All right, I'm going to sit and read this to you guys. Now note these agents, they're going to block acute infection of cells. But they're not going to be so active in chronically infected ones where you've already gotten the reverse transcriptase to make the viral DNA. They just won't work as well there. As I say, they're both inhibitors. They'll slow down the reverse transcriptase, and they're substrates for it. They lack that 3' hydroxyl group. Now, these are examples, you guys. Internal medicine doctors, even infectious disease doctors, what we all do is we refer patients to HIV clinics where you can specialize on this stuff. Because there's a lot of side effects, there's a lot of balancing. It's not something you casually do like antibiotics. But what I want to pick at is, here's our 4 bases: thymidine, cytidine, guanosine, adenosine. And all of these compounds, looking at zidovudine over here on the left, it has to get converted to the triphosphate. And it's thymidine kinases that do that, or deoxycytidine kinases, the cytidine, on and on. it's the same idea over and over again. And we wind up with all of these triphosphates that are formed. Maybe I'll also just mention each of these agents here, some of them are just delineated by letters here. These are all prodrugs that need to be converted. The conversion to that triphosphate, and then they'll get incorporated. Okay, that's the most important group, but it's not the only group by any means. And as I said, continuing on with that. Why is that last one diphosphate? You probably caught something I'm not aware of. Oh! That's interesting. Dustin, I'll have to look. I'm not sure. It doesn't seem like it would work in my mind, because in my mind they all got converted in the triphosphate form and got incorporated. Hold on a second. Yeah, that was the nucleotide. It already had a phosphate group in it. The tenofovir did. So there is actually 3 phosphates in there. There are 2 phosphate steps, but you started with a nucleotide, not a nucleoside. So no, it's not a misprint. That's correct. This is the nucleotide, and it has a phosphate group. Okay. So, looking at some of these major players here, there's too many to know, you guys. So look at your drug list. Is a good place to go. And it's somewhat whimsical which ones we pick. But cytobutene is a big one. It was first, and surprisingly, still one of the most commonly used. It causes an anemia and a decrease in red blood cells, so we manage that with erythropoietin, and even some suppression of bone marrow. Despite that, it still gets a lot of use because it's so good at pushing down the viral counts. A lot of these other drugs, neuropathies, even a pancreatitis, lamivudine is the one I mentioned. Abacavir is a newer one with perhaps fewer severe toxicities. We'll see about that. Maybe I should stick another one in here because I believe it's on the drug list. Number 8, and that's the emcitriptine, EMTRI. CITABINE. The emtricitabine and the lamivudine. These are the least toxic. The nucleoside reverse transcriptase inhibitors. Okay. The next group is the protease inhibitors. And notice the Navir sign on here. Maybe I'll just call them the Navirs. Because that suffix does help. There's so many of them that keep coming out. No, there really isn't any connection to gemcitabine that I'm aware of. They're bases. Gemcitabine was a base. It was an analog that got incorporated into DNA and inhibited DNA polymerase and ribonucleotide reductase and all that. But that was a base that was expected to be a non-infected cell. Let's see. HIV HIV-1 encodes this protease that's required for cleavage of these precursors that generate, so you've got these precursors in the virion particles, generate the proteins. They even include reverse transcriptase, one of them, an important one. So this group of drugs will block viral maturation, therefore they're active in both acutely and chronically infected cells, because the cell that's releasing these virion particles, now the particles won't be able to mature and attach and infect other CD4 cells. So resistance is a big problem used as monotherapy. You don't use them as monotherapy. Usually use them with two nucleoside analogs. It's real common in HIV therapy. Just say the usual HIV therapy. It's a triple cocktail. It's three of these drugs, and common to the nucleoside reverse nucleoside reverse transcriptase inhibitors and an NRTI and a protease inhibitor. Little note on the protease enzyme. The protease enzyme is actually a dipeptide structure. So it's got two amino acid chains. And that's just not seen in humans. So the protease inhibitors bind to that dipeptide, inhibiting the enzyme. Resistance occurs at some point mutations in the bull gene. There's not complete cross resistance between different protease inhibitors, so you may be switching between one protease inhibitor and the other. This is an example here of human proteases. There's certainly a lot of them. Something like, for example, renin. It's just a single, it's an aspartate protease actually. So it sounds so similar. But it only has one chain. And therefore we can get some really good selectivity, because when you think about inhibiting protease enzymes, it's like, my goodness, protein. It takes us back to the heart failure and the neprilysin inhibitors and so on. It's very, how could you get some selectivity here if you're inhibiting protease enzymes? Well, it's the dipeptide structure. A note on metabolism of these drugs. I usually don't like talking about metabolism because every drug is metabolized. We can't remember it all. But sequinavir, indinavir, nalbenifir, and many of the other navirs, they're pretty quickly degraded by the 3A4 enzyme, cytochrome P450 3A4 enzyme. Ritonavir is not a very good drug. It's not a very good protease inhibitor. So it's a weak protease inhibitor, but it slows 3A4. And therefore, it's added to other navirs. So when I think of ritonavir, the way I remember it, I'm out of room here, retain. It helps to retain the other protease inhibitors it's with so they don't get metabolized so quickly. Retainavir, if you want. Okay, then there's the non-nucleoside reverse transcriptase inhibitors, the NNRTIs. Believe me, all these get really useful. That's why we treat this disease so well now. 25 years ago, when Magic Johnson, probably a little more than that. It's about that. 25 years ago, when Magic Johnson got HIV, everybody just assumed he was going to be dead in a year. The idea that he could still be alive today and doing well is remarkable. But it's because they've got such a selection of drugs to switch back and forth, so to fight the resistance. But let's see, these non-nucleoside reverse transcriptase inhibitors, they do the same thing as the NRTIs. They just aren't nucleosides. So, inhibit the reverse transcriptase but are not nucleoside analogs. Again, resistance occurs quickly, but look at the side effects. The rash and headache, hey, that's pretty mild. So we'll stay with those and switch them in and out. They can be part of the triple cocktail. Okay. Another note. These have no cross resistance. With the NRTIs. So if somebody's become resistant to the zidovudine, and you want to go with a non-nucleoside, you don't have to worry about cross-resistance. All right, that's the end of the three main groups. There's some others here that we're going to look at, but so we've got the NRTIs, the NRTIs, and the protease inhibitors. And that's what you're going to see people mostly on, is a combination of those three. They actually are getting combo tablets so that you can take it all together with one tablet. Okay, why don't we take a break there, and we'll come back in 10 minutes and finish this up. Do they work at steps 3 and 8? What do you think? Oh, well, let's go back and look at the protease inhibitors. Yeah. Now this is where a protease inhibitor is going to work. It's going to be on 8. Why are you thinking step 3? Step 3 on there is the reverse transcriptase. So this would be the NRTIs and the NRTIs. Let's see. Yeah. Protease inhibitors don't do anything to reverse transcriptase. Oh, they block it. Yeah, okay. They're blocking the maturation, though. We don't want to say once the reverse transcriptase is in the cell that it's going to be active at that point. Once that reverse transcriptase is active, protease inhibitors aren't going to do anything. So. Is that better? Okay. All right, let's take a break, and I'll see you guys in 10 minutes. We'll finish this up. page a little bit, you guys. I just want to be sure that we're clear about this. Look at the nucleoside reverse transcriptase inhibitors. These actions, zidovudine, this will occur in all cells. Whether we're looking here, we're looking up here, that occurs in all cells. But it's got a higher frequency in the infected cells due to that sloppy transcriptase. An important point. I wasn't clear about it. I want to make sure I was. Okay. The next two compounds, and we're getting pretty close to the end of the HIV drugs here, are drugs that inhibit the viral attachment and entry. In this diagram, I'll admit it's fairly complicated. It's more than what we need. But here's our CD4. This is, of course, our host plasma membrane, so this would be the CD4 cell. Our chemokine receptor is sitting here. And when there's contact between the GP41 and the GP120 with that CD4, it starts a series of convolutions moving around, and it forms this fusion peptide. And that keeps rearranging, and I don't want to get into any more than that. I'm just going to say it keeps rearranging until we finally get to the point where here's our CD4, and here's our HIV, the particle. And now we've got a way of passing through there. So that's the importance of that GP41 and the GP120. What infuveritide does is it traps that stock. It doesn't allow it to rearrange. So it binds to a hydrophobic group of GP41, but more importantly, it prevents the refolding. Even more important than that, it blocks entry. That's the big thing. So that's what the immuviritide does. The miraviroc blocks binding, and I'll just write this down at the bottom. Miraviroc. It blocks the binding of the GP120 to the chemokine receptor. You can actually work for a week at an HIV clinic as a student following around an infectious disease doctor and go, pull out these notes and go, man, I didn't see any of this miraviroc or any of this imfuveritide. When you think about it, you guys, these are proteins. They're going to have to be injected. Everything else we've talked about up to this point, the protease inhibitors, NRTIs, that can all be given orally. But these compounds need injection. And that's not something to memorize, but it's just an explanation of why you might not see them. They're nice backups to have. And the last group are these integrase inhibitors. Raltegravir, that gravir means it's an integrase inhibitor. And there's Me Too's out there now that'll come along, and maybe the dosing's a little bit easier. But all these drugs do, they bind to the HIV integrase and prevent that strand transfer. So here's our proviral DNA, which is just all this means is it's modified DNA ready for insertion. And it's not going to happen if you inhibit the integrase. HIV complex. That's why if you're going to really be working with patients with these drugs, you need to work in a clinic that's explicitly an HIV clinic. But basically, we start somebody on 2 nucleoside analogs and a protease inhibitor. A non-nucleoside analog may be switched in place of the protease inhibitor, so you can have somebody on 3 of the nucleoside inhibitors. And they start playing around with all these different. This is actually a fairly old table. It's your information only. I wouldn't dream of asking you to actually learn the different therapies and how to substitute is enormously complex. But just keep in mind, it's usually a triple therapy. It's the most common. And it gets hard enough where quite often manufacturers now are combining these different drugs into one tablet. Just to make the compliance a little bit easier. I had a patient call me up last week at the call center and he goes, I've been HIV positive for 20 years. They switched me to this new drug and I went, And they go, I take it 1 time a day in a tablet. That's got to be a mistake. And I started laughing and I said, no, that actually is with the new therapies. It's a tablet. 2 or 3 drugs, you just take it once a day. So pretty remarkable what they're trying to do to try and make this a little easier. Treatment with hepatitis C, wow, has this come a long ways. For years, it was these 2. Peg interferon alpha and ribavirin. It was the only treatment for hepatitis C. It really wasn't considered curative, but if you could tolerate it, not have side effects, you could get good suppression of the hep C. But then a protease inhibitor came along, the semaprevir. But really, the big kahuna here is the sofosbuvir. And it's a polymerase inhibitor that I'll talk about briefly down below. And for a while they were using that, saying, okay, let's use sofosbuvir plus semaprevir. And semaprevir is it's an inhibitor of protease, as I said. And you might think, wow, these treatments, it's like 8 to 10 weeks and it's $100,000. You're like, you're kidding, it's $100,000? It's like, yeah, I'm worth every bit of it. I'd take a mortgage back out of my house if I had hep C for this. Obviously, I've got insurance, so I wouldn't have to, but if I didn't, I'd pay for this in a heartbeat. Well, because it works so well, and it is curative. But what we found is, you might think the drug companies are making a lot of money. These protease inhibitors keep getting switched out. One of the mainstays has been the sofosbuvir, but the semaprevir has now been replaced. And I'll just say see below. And what the trick with the sofosbuvir is it is a nucleotide. It's got the phosphate in there. It's not a nucleoside. Kind of a funny looking molecule. Therefore, you have the initial phosphorylation. And that was often the rate-limiting step in the hep C antivirals. They couldn't get a DNA polymerase inhibitor work because you needed to get this initial phosphorylation cell. So I say down here, as I typed in, it's an inhibitor of the HCV, or hepatitis C virus, RNA-dependent RNA polymerase, which is essential. It's a nucleotide prodrug that undergoes metabolism to form the active analog of uridine triphosphate, which then gets incorporated, and it'll act as a chain terminator. Sounds kind of familiar. So it's one of these false bases, essentially. But it's a nucleotide, and that was the rate-limiting step. That's the big one. Another key along that lines is with the hep C virus. The hep C virus is not inserted into the host enzyme. And therefore, we have some pretty good selectivity. Let's see. So what they've added to it now, they've pretty much stopped the protease inhibitors, and we now add these strange compounds. We call them, let's see, HCV NS5A inhibitors. All right, HCV NS5A inhibitors. And the two that we're seeing, you can have sofosbuvir plus ledipasvir. And then you've probably seen advertised as the Harvoni. And Harvoni's actually stayed around a little bit longer than some of these others that, we've had curative, but then we keep getting curative more quickly, curative with less side effects. Or you can have the sofosbuvir, and now another NS5A inhibitor has come out, and it's called valpatisvir. That's very new. That's like less than a year. It's a new compound. It's probably going to put the Harvoni in for a run for its money. So maybe the Harvoni was actually pulling in $2 or $3 billion a year for a couple of years, and then it's done. So you have a great cure for Hep C. You got 3 or 4 years out of it. That's not a good return for such a breakthrough drug. So I look at this and I think, wow, $100,000 is a lot of money. But on the other hand, it's like, these companies quite often their drug went out there before it was replaced by something else pretty quickly. So you've got these 2 combo tablets, and sometimes ribavirin is added. It depends on the strain. But we now pretty much expect to cure hepatitis C in a patient, so we don't wind up with all the chronic liver troubles. A note on this NS5A, we don't know what that does. This has an unknown function. It's like, then why did somebody think to inhibit it? So we don't know what it does. We gave it a name, and then we found a drug that inhibits it, and wow, it seems to work better than using a protease inhibitor with a sofosbuvir. Okay, some notes on tuberculosis. I had a lot of resistant strains, of course, around the world. We're still doing pretty well in the U.S., but there's areas in Russia where more than 50% of the strains are resistant and causing a lot of trouble. But keeping this as simple as we possibly can. Fatty acid synthetase 1 and fatty acid synthetase 2. And they produce these glycolic acids that are a major constituent of the cell wall. There's a caption here says glycolic acids produced by these cross-linking of the fatty acids. Fatty acid 1 is inhibited by pyrazanamide. Isoniazid inhibits the second fatty acid synthetase. You won't get these glycolic acids. And with that, you get a damaged cell wall. Additionally, look at this diagram on the right. The arimidogalactan will actually hold the glycolic acids in place. So you can inhibit the formation of the glycolic acids, or you can inhibit the formation of the arimidogalactan, and the glycolic acids won't stay in their proper place. Essentially, again, you've lost this outer incorporated into the chain and causing termination. So, yeah, you're hitting, the first phosphorylation's already done. And you can bypass that since it's a nucleotide. So, let's see, look at the isoniazid. Major toxicity is hepatitis. And the way I've written this, you guys, it causes some confusion. I was looking at it the other day, I went, oh, that's what students are reading. That's why they get confused. All right, it does cause peripheral neuropathies due to interference of pyridoxine metabolism. Pyridoxine is B6. If you give the B6, there is no neuropathy. So the B6 will prevent the neuropathy. I've always kind of wondered, why isn't the B6 just included in a tablet with isoniazid? Because as a pharmacist, whenever I see a patient on isoniazid, I always look to make sure they've got the B6. You guys, I started practicing pharmacy in '94. I've not caught it once where somebody dropped the ball. They always do it. Everybody knows it. So, but the big problem is hepatitis. So that's the major drawback with it. I'm 60 years old. If I converted to a positive TB, I didn't have the disease, but I had a positive conversion, they'd say, sorry, Dr. Z, you're not getting our isoniazid because they're too concerned about the hepatitis. Somebody as young as you guys, less than 30, they would easily go ahead and get the isoniazid. So the incidence increases with age. But despite that, isoniazid is still the big drug for treating TB. You have to add other things to it, but it's the big one. Rifampin inhibits bacterial DNA-dependent RNA polymerase. One of the neat things about it is it can turn things orange. Your secretion's orange, kind of pretty, kind of strange. Pyrazanamide causes some hepatic injury. Streptomycin, this is an aminoglycoside. And as I point out, let's see. Yeah, we're going to be doing regimens for at least 6 months. So what's the problem with giving streptomycin for 6 months, you guys? Kind of unfair to ask. The ototoxicity, yeah, it's a toxic drug. Okay, good. How do you give it? Highly polycationic, extremely water-loving. Yeah, it's toxic, plus it's an injection. Are you kidding? For 6 months? I've never even looked up how often you have to give it, but therefore it has rare use. And it might be a nice card in the deck if you ever have some real resistance problems, but you're not going to see it. Ethambutol, the last one there, is someone that decreases the ribinogalactan, so you don't hold the glycolic acids in place. Causes a neuritis, where you get some blurry vision and changes in color. But isoniazid, despite the problems with the hepatitis, it's the best. So what do we typically do? Let me go write this in. It is used alone for a positive TB skin test. Without the disease. Put a hyphen in there, in a young person. I believe you have to be less than 35. They may have changed it to 40. You have to be younger than 40. Yeah, 40's young to me, guys. Haha. Let's see. Typically, rifampin and isoniazid are used for the first 2 months. You have to break the person in. You have to induce them. You have to get that It's an interesting question, Kevin. I'd have to look. Oh, if I got a PPD and I'm 60, they would say, well, you don't have the disease. They would wait for the disease to express itself. Hopefully I've walled it off. If I don't have the disease, I have walled it off. Maybe I killed it totally. But you're better off just, doing no harm in somebody my age. And if I do start to develop the full active disease, then we'll go into this full treatment. Kevin, I'm going to punt on your question. I'll come back to it. I want to go look. I don't have a good answer for that. Let's see. I want to make sure I wrote this correctly. Yeah. The big thing is you're going to have to go for several months. And, 6-month regimens, you use the isoniazid and the rifampin, but you're going to add the pyrazanamide and the ethambutol for the initial 2 months. Okay, the anti-malarial drugs. We've had some interesting conversations in the faculty meetings. You guys, I'll be candid, I don't like presenting these. When people say malaria is a worldwide problem, I go, yes, it is, but it's not in the U.S. And if you're a physician and you're born across seas, I would suggest you read up on it. But I think anything, I was sitting in a meeting with an infectious disease doctor. I just leaned over and I said, how often do you see a malarial infection? And he goes, you mean the full-blown infection, or you just talk about prophylaxis? I said, no, the infection, where you're going to treat the infection. He goes, as an ID doctor, I see a case every 2 years. I'm like, see, this is where I feel like med school, the boards they just overblow stuff, you guys. But that's my 2 cents. You better not listen to me, because this stuff can be on the boards. It might even make it onto our 4th exam here, so. But let's take a look at this. I'll quit my groaning. But there's this life cycle where we start off with the pretty well delineating the caption here. These gametocytes transfer to a mosquito when it comes and bites, and then the mosquito does different things with it, forms an oocyst and so on. On the outside wall of the stomach, and the sporozoites migrate to the salivary glands, and then the mosquito will transfer that Plasmodium species into its saliva, and then the sporozoites will enter the bloodstream. They go to the liver initially, and then there's a lysing of the hepatocytes due to that. And when that happens, they're converted into merozoites, and sounds a little biblical to me, the Old Testament, you guys. But anyhow, this enters into the red blood cells, of course, because that's where they're going to get their food from. And of course, some of these go into the, so it's a small percentage here. Some merozoites differentiate into the gametocytes, which could be ingested by another mosquito, and you get this problem continuing. There's even dormant forms of this disease that can remain in the hepatocytes for months or years before released into the circulation. So that's a brief overlook at it. But human malaria is caused by 1 of 5. The Plasmodium falciparum is the worst. It's the most serious type. But there's the Vivax, Valley, the Malariae, and the Knowlesi. Chloroquine is actually an interesting drug. And as we'll see, quin, methylquin. If we understand how chloroquine works, we have a good idea how quinine, quinidine, and methylquin work. And they've studied chloroquine extensively. It was an extremely hard drug to get resistance to, despite the fact when somebody's diagnosed, they have around 10 to the 12 trillion malarial parasites in them. And yet chloroquine for years and years showed no resistance, but finally it did show up. Let's see, this is the Plasmodium food vacuole. And it's a specialized food vacuole. There's this proton ATPase, which is crucial because therefore we have an acidic environment. But if it's acidic, and chloroquine is a base, therefore we get protonated chloroquine that has a charge, and it's ion trapped in that food vacuole. So you'll see concentrations that are far higher of the chloroquine in an infected red blood cell. So you have high chloroquine concentrations in an infected RBC. But what is it that it does? These bugs love the hemoglobin, and they love the amino acids. And the amino acids get shunted out via this PFCRT. PFCRT is Plasmodium falciparum chloroquine resistance transporter. Not something that you're going to see on the boards or on my test, you guys, but just they've studied this so carefully and looked at it for so long because it is such a world health problem. Well, normally we chew up the bug chews up the hemoglobin, you wind up with all the amino acids, but you've got that iron ring, the porphyrin ring there. And that has to be done something with because that is toxic. So what the bug does is polymerize that. And this polymerized heme, the hemozoin, is not toxic. And what's going to happen with the chloroquine there, this protonated, it's in that high concentration, we wind up with this accumulation because we're blocking this polymerization of heme. So we're going to get this unpolymerized porphyrin and get a lot of oxidative damage and toxicity to the parasite. So unfortunately what happens, the next line down there, resistance to the falciparum occurs by alteration of that protein. And once that protein, that transporter gets altered, it allows efflux of the chloroquine from the vacuole. And when that happens, that's going to render the drug ineffective. It's not in that high concentration anymore. So, unfortunately, chloroquine just basically can't be used against falciparum anymore. It's still the drug of choice for treating the other forms of malaria, but we've lost our great gun, unfortunately. So what do we have? Quinine and quinidine. Quinidine was the 1A antiarrhythmic. That would be thinking in a similar fashion to chloroquine. And that's why I cued you into the quin. These drugs come along the QT interval. I hear the groans, you guys. I know. We love the antiarrhythmics. But the antiarrhythmics were cool, but that was a class 3 property of the antiarrhythmics, even though they were class 1. a cinchona tree. And people, when they have this disease, like in Africa, I don't know what a cinchona tree looks like, you guys, but they go eat the bark, and they get overdosed, and they wind up with this syndrome that we call cinchonism, where ear ringing, a lot of funny CNS effects, overdosing, yeah, you're going to see it. Could it be on a board exam? Possibly. I'm trying to keep these malarial drugs as simple as possible, so I haven't put it in there. But maybe the idea of eating a cinchona tree bark sounds kind of attractive. Let's see, looking at the mefloquine. No, that should go away. That's a toxicity. As you drop, as the plasma concentration drops, that goes away. Because it would happen with quinidine when we give it as an antiarrhythmic. And you'd realize you're getting a toxicity, and you lower the dose or stop the drug altogether, and it would resolve. Very possibly. I mean, those are sodium channel blockers. There's sodium channels in our brain. It's just a CNS effect. Mefloquine, again, is not unknown. We really don't know how it works, but it's very similar to chloroquine. You get prolongation of the QT interval. You get these kind of neat neuropsychiatric effects. So wild dreams, depression, hallucinations. All of these, you can get arrhythmias, but they will resolve when the treatment is over. They sometimes hang around for a few weeks, which is a little scary. But when we look at those quins, whether it's mefloquine, quinine, quinidine, similar mechanisms of action and similar side effects, the QT interval. I don't know if mefloquine causes this cinchonism. I associate that with the quinine and the quinidine. Okay, artemisinin, kind of wild drug. It's frequently the first-line drug for treating the falciparum, which is the worst form, of course, of malaria. This compound, we're not quite sure what it does. It does form this free radical. It has to be activated. So it's a prodrug. As I say down here, it has to be activated by iron. And once it's this free radical, it's going to alkylate. Think about the alkylating agents. They form the carbonium ions, and you got this electrophile that went after the nucleophilic bases. You'll get an alkylation, and sometimes drug of protein, sometimes of the heat. But it's like, so how does this kill the bug? And probably by inhibiting a calcium pump is our best guess. One of these adducts that's formed is the Plasmodium falciparum ATP6. It's a sort of a calcium ATPase transporter. So that's our best guess. But this is the drug that affects the gametocytes, and therefore can decrease transmission of the malaria. Short half-life leads to difficult dosing, so sometimes it's given with mefloquine, which is a longer half-life. So the resistance we've seen with it involved mutations in that calcium pump. So side effects are pretty mild compared to everything else we've looked at. Then there's a sulfamethoxyl trimethoprim analog, and that's the sulfadoxine pyrimethamine. And sulfadoxazine is a PAB analog that inhibits the parasitic dihydroopterate synthetase, an enzyme in the folic acid synthesis pathway. Again, humans get folate in the diet. And pyrimethamine will act very much like the trimethoprim. It's going to inhibit the dihydrofolate reductase, the DHFR. to say about it. Not very toxic compared to some of the other drugs. The thing is, when you're going to a particular area, you're going to know what works in that particular area. What's the common type of malaria, and what have people been using? So, the atovaquone and primaquine. Let's see. When you see quone, you can think of quinone and electron transport train. And let's see, primaquine is actually a prodrug, and it'll get converted to quinone. Well, this goes back to rheumatoid arthritis, we talked about this a long time ago, but the dihydroorotate gets converted to the orotate, and that will go on to form pyrimidines. But in that process, the dihydroorotate dehydrogenase gets reduced. So it picks up electrons, and those electrons have to go to the electron transport chain. And when that happens, this dehydrogenase oxidizes, and then it can go back and convert the dihydroorotate back to the orotate again and continue pyrimidine function. So we need this cycle to be going. And what happens here is that, I think I've got it typed down here, yeah, atovaquone antagonizes the interaction between quinone and the BC1 complex of electron transport. And when you do that, that's going to disrupt the pyrimidine synthesis because you're not going to be able to regenerate the oxidized dehydrogenase. So atovaquone, this has a very similar structure, very similar to the quinone or ubiquinone. So it's an analog to the ubiquinone. Primaquine, we're not sure of its mechanism of action. It may decrease electron transport. But that's somewhat speculative, and the boards usually don't go after speculative stuff. So it may simply, or increase the number of oxidized compounds. Where they're liable to ask about this on the boards is that it's famous. I mean, this is a famous side effect. I mean, it even made it into episodes. I can remember episodes of MASH. You guys have probably seen reruns of, but the idea was you could not use it in somebody with a glucose-6-phosphate dehydrogenase deficiency. What does glucose-6-phosphate dehydrogenase do? It reduces NADP to NADPH. And the NADPH will convert the oxidized glutathione to the reduced form. So oxidized glutathione just means you've got, remember glutathione was a tripeptide. We talked about it, it's been a long time. It's a tripeptide, and it has cysteine in it that has that sulfhydryl group. Well, when it's oxidized, you've got two of those cysteines bound to each other. And when those sulfurs are bound up, they can't do anything. The idea here is that we need to break down toxic oxidant compounds. Well, NADPH will convert this to the GSH plus another GSH. And these will go bind the oxidant compounds. And that's going to protect the red blood cell. So, somebody doesn't have much, just genetically, they don't have, people of Mediterranean descent and some others, don't have a lot of glucose-6-phosphate dehydrogenase activity to start with. Well, they're going to need it if you're giving them Primaquine, because you're going to be forming a lot of toxic oxidant compounds with the Primaquine. We think that's maybe, as I listed up there, one of the ways it works. Well, Primaquine causes an increase in the number of these oxidized compounds. So somebody has a deficiency of that enzyme, they have hemolysis. And they get really weak and they feel lousy. They get very anemic. Okay, some notes on some immunosuppressive agents. I can remember being in the 5th grade when the first heart transplant was done. And everybody was very excited about it. It was done in Cape Town, South Africa by a famous surgeon. In a few days, the patient died. I was kind of like, wow. And that was really what happened through that would have been the late 1960s, but through the 1970s, in the 1980s, the bone marrow suppression just made these transplants really hard to do. We use these cytotoxic agents. And these cytotoxic agents, yeah, they would suppress the immune system, but we wanted to suppress just the lymphocytes. But we also got the bone marrow suppression, and that is not wanted. You don't want the bone, you don't want the neutropenias. You want to suppress the lymphocytes. And when you suppress both of these, if you suppress the bone marrow and the lymphocytes, it leads to these infections. And I can remember the person who died within a few days of an opportunistic infection. It's like, wow, what were they giving him? But if they didn't give him that immunosuppressant, he obviously would have rejected the new heart. Well, somewhere around 1985, about the time acyclovir was coming out, cyclosporin came on the scene, and that changed everything. And with cyclosporin, bone marrow suppression is no longer needed. We don't have to put up with that. So that was the big game changer. Cyclosporin and tacrolimus will decrease the lymphocytes. But no effect on the bone marrow. So looking at this, then there's also the adrenal steroids, some cytotoxic drugs we'll mention, the antibody reagents that I really don't talk about in this handout. I don't see them being used very heavily. But I do see a lot of cyclosporin and a lot of tacrolimus. And let's take a careful look at how they work. The caption I put in here is really good. But we get the antigen binding. This is obviously the T cell receptor. Caption over here. Activation of the T cell causes, among other consequences, an increase in intracellular calcium, which is going to activate a phosphatase. So the calcium will go bind the calmodulin, and here's the calcineurin. This is the phosphatase. Obviously, this is a lymphocyte that we're looking at. activated, there's this transcription factor that we call a nuclear factor of activated T cells. It loses its phosphate group, and with that it goes into the nucleus, combines with another transcription factor, and we get all these different interleukins that are going to lead to the lymphocyte proliferation. Well, jump down the caption here. Cyclosporin, in association with this binding protein cyclophilin, and tacrolimus in association with this other binding protein, they associate. With the calcineurin in the interfacial surface. And therefore, they're going to inhibit the calcineurin activity. So they slow down the calcineurin. There's another pathway that's not mentioned on here. It is mentioned in the caption. This octamer activating protein, which also requires dephosphorylation for transport. So basically what these are doing is inhibiting a phosphorylase, a phosphatase, this calcineurin, and therefore we're not getting the transcription factors located into the nucleus, and we're not getting all the cytokines and interferons and so on to be released for the lymphocyte proliferation. So you can see this drug has nothing to do with bone marrow. No effect on bone marrow. Toxicity, some renal problems. It's not like, there can be some drops in creatinine clearance. It's not a kidney killer necessarily. But the main thing we watch out for is a decrease in the creatinine. But it's great. It's changed everything. Okay, let's take a break. We'll come back and take a quick look at the, we'll finish this up and take a quick look at the odds and ends handout and be done, you guys. So, see you in a few. this up and finishing it. Kevin, why were you asking, why is dapsone a part of leprosy treatment, but not TB? Why would it be for TB? The more I thought about that, it's like, why would you use dapsone for TB? Yeah, the dapsone works very much like the sulfa drugs. It inhibits the dihydroxyapatite synthetase, but it does it of that particular bug of the leprosy. I don't know. I'm not aware that it works on anything. But these enzymes have the same name, like dihydrofolate reductase, just by going from humans to bacteria to protozoas and so on. So it's particular for that particular enzyme that's in the leprosy. But I've never heard of anything like it for tuberculosis. Yeah, they are both mycobacterium. But we see this with antibiotics. Clindamycin works against a lot of the anaerobes, but it doesn't work against Clostridium. That happens where we see that. So it's, you work against one form of strep and not another form of strep. So it's just a different form. Ah, shoot. I have no idea what I just did. We'll get this back. Good. Okay, page left here, and then we're going to look at the odds and ends. We, of course, can still use the adrenal corticosteroids, the prednisone and the prednisolone. They'll inhibit lymphocyte proliferation also. If you go back to the inflammation handout, that was one of the main things they do. These are steroid hormones. And because of that, they're going into the nucleus and altering transcription. And a lot of the cytokines have a response element that is a target of the complex formed by the associated corticosteroid with its receptor. Excuse me a minute. I'll never be able to read this chat room with this small room. But we get a good inhibition of T cell proliferation. The problem with these drugs, particularly in high dose, is, for one thing, people don't like a high dose more than a few days. 40 milligrams of prednisone, people feel like somebody's infusing Starbucks coffee into them. They don't like it. So you got to get down to a low dose instead of 40 milligrams, down to about 5. There's just too many side effects is one of the biggest problems here. So toxicity too many. And you can use these chronically with a low dose. And they can be added to the cyclosporin. But then we get back into the cytotoxic drugs that are also going to have an effect on bone marrow. And right away, that's what we see. The mycophenolate, certainly with the cyclophosphamide methotrexate, you're going to see the bone marrow get hit. Azathioprine is listed here. It's a strange drug. It's converted within the cell to mercaptopurine, which inhibits purine synthesis. We talked about back in the cancer lectures. But lymphocytes are always sensitive to that because they have to make purines. They can't scavenge them from other ways. So they have to start from scratch to make the purines. So if you interrupt that purine synthesis, you'll inhibit the lymphocytes. But azathioprine is a prodrug. So why are we giving a prodrug? Why not just give the mercaptopurine? We don't really know. Perhaps the azathioprine has a better uptake into the target tissue, into the lymphocytes. It does just seem to work better. It's kind of fallen off, and I see a lot of the mycophenolate, mycophenolic acid, which is the metabolite of this compound, is an inhibitor of the inosine monophosphate dehydrogenase. Again, an enzyme critical for the de novo synthesis of purines. And if you inhibit the purines, you're going to inhibit lymphocytes. finally, cyclophosphamide and methotrexate. Yeah, these are mainly used not for transplant, but for autoimmune diseases. Okay, let's pull out that last handout. I've got good news and bad news on this one, you guys. There's a lot. There are a lot of herbal medicines out there. And we'll see why in a moment here. I do want you to understand some of the principles I talk about. I'm going to pick on a couple of them. But most of the actual herbal medicines that I've got listed in this handout, they're not on your drug list. You're not responsible for them. It's just overwhelming. And I'll talk to you about ways to try and handle this. There's some great sites to go to because you're going to get particular questions from patients saying, what about this drug that I'm taking? And I bet 75% of the time when they ask me, it's like, I've never even heard of that. So some of the retail pharmacists do better at this than I do because they're selling all that stuff right there in a lot of cases. But let's look at this. First of all, what is an herbal medicine? Something that's made from a botanical is an herbal medicine. And there we go, Ben. And it's to improve health, of course. So we call these herbal products, botanical products, phytomedicines. The big change that occurred was back in 1994. And totally different legislation than what we're used to thinking about with drugs. In 1994, the Congress passed the Dietary Supplement Health and Education Act. And what that did was that severely limited, the FDA's control over products that contain a labeling of dietary supplements. So suddenly, if you can get anything out there called a dietary supplement, there's not much control on it. Manufacturers, this goes back to pre-1938 Food, Drug, and Cosmetic Act. Manufacturers don't have to prove safety or efficacy before they put it on the market. It's like, oh my goodness, they don't even have to show that it's safe. With this act, Congress acknowledged that consumers believes the supplements provide health benefits. They want greater responsibility for deciding if the herbs are helpful to them. In some ways, they needed to do this, or the price would just be obtrusive. The whole point of this was it kept the price down. If you're going to require all of the studies that are done for a new drug application, these herbal medicines will skyrocket. That's not what consumers wanted. So these drugs can be marketed with limited proof of effectiveness or safety. Vendors make claims. The FDA can pull a product off the market if it's proved dangerous. So there is the legislation to do that. For example, back in 2003, the Food and Drug Administration abandoned ephedra because it caused cardiac arrhythmias and some other problems. So, in the absence of any kind of federal legislation on the safety of these drugs, a few private sector groups have looked into this. U.S. Pharmacopoeia looks at the purity, Consumer Lab, Good Housekeeping. Actually, Good Housekeeping is one of the better ones. But what they look at is, okay, does the product meet standards of quality? What about the purity? What about the manufacturing process? It actually is not easy to take a plant and convert it into a tablet. That takes a fair amount of work. And is it good and clean, safe practices? Does the label accurately reflect what's in the product? That's a big one. Is the thing free of contaminants such as heavy metals or pesticides? These are herbal medicines. So that, it's not surprising we might have some of those in there. These programs by consumer labs, Good Housekeeping, and so on, they're not required to report herbs that fail to meet these standards, only those that pass. Now, if something doesn't pass U.S. Pharmacopoeia, it doesn't mean it's harmful, it doesn't mean anything, it just wasn't pure enough to meet their standards. Yeah. The good housekeeping actually requires a product to prove that it's safe and effective. And that's not like a phase 1, phase 2, phase 3 study, but there's something there that they showed something, some sort of basic study, a pretty loose study to at least show that people can take it and expect some sort of a benefit. So, let's see, not as careful as the FDA, not by any means. Alright, so we've got these compounds put out there that can be parts of plants, and with the idea there that people will talk about standardization. That's a key word. And when they talk about standardization of these products, they're not saying that each lot is the same. That's not necessarily what they mean. But quite often standardization involves standardization can also provide a measure of quality control. Sometimes it means they're using a standardized practice to make the tablet. Standardization to make the herbal. So it can mean that. Sometimes, here's another problem. You got this herbal medicine, you ground up these leaves, okay? You got these leaves. There's thousands of compounds in there. What's the active compound? How can we talk about purity when we don't know what the active compound is? So quite often they'll look for these chemicals that they call markers and see if those are the same. But since you don't know what the active ingredient is, it can be a little bit hard to trace down. The next paragraph there is more what I was talking about. What is standardization, incorrectly referred to uniform manufacturing processes. Well, let's say a product is standardized. That's not what I think of it. Ideally, back in the 1700s when they were using digoxin, and they were pharmacist was grinding up the foxglove plant, the amount of digoxin in there depended on the growing season, how much water they had, how much sun they had. All these things affected how much digoxin was in there. It's a lot like this with these herbal medicines. So, components responsible for the effect of most botanicals have not been identified. For example, the example I give here, the senicides in the botanical senna are known to be responsible for the laxative effect of the plant, but many compounds may be responsible for valerian's relaxing effect. So valerian has a relaxing effect due to what? And finally, I think people really are making a mistake when they assume it's safe because it's natural. It's true. Talking with my friends at Lilly, they'll tell you, if we go and synthesize a compound that no human has ever seen, there's a better chance of it being toxic than something that's been around for thousands of years while humans have been here. So, but still, there's a lot of natural things that are very toxic. And finally, as I put here, many of our prescription drugs are extracted from plants. So did a drug become dangerous due to the purification extensive testing? So they purified from a plant, they tested it, and now it's dangerous? So you can take a pill of digoxin, you can eat that foxglove plant and not know how much you're getting. This is the whole problem with the herbals. And fortunately, a lot of them don't do anything. I think there's a lot of money being wasted here. I'll pick on a couple of these. There's a lot of strange names here. A lot of signals of desperation that we have, trying to find something. But, using ginkgo for dementia, it's like, oh my goodness, do you know how hard it is to treat a neurological disease like dementia? And what we found here was not very effective. Some of the ones that do work, glucosamine and Yeah, this is an endogenous monosaccharide synthesized from glucose, found in mucopolysaccharide, blah, blah, blah. It's often paired with the chondroitin in the treatment of articular diseases, arthritis and so on, osteoarthritis, which is wear and tear. These drugs do work. They reduce inflammation. Yeah, it doesn't seem to work so well for back. But no, the way they're advertised, and you would think that they, lay down new cartilage, and that's not the case at all. These do not restore joints. They actually have a very similar effect to NSAIDs. They're a little bit slow. But if you were to compare somebody on glucosamine chondroitin with somebody on a good dose of ibuprofen, you would find 6 weeks out there might not be much of a difference. So there is a real effect there. Let's look at saw palmetto for a minute. Used primarily for symptoms related to prostatic conditions such as BPH, as guys that are getting old. Very, very questionable efficacy. Certainly doesn't work as well as an alpha-1 blocker. It's the kind of language we're talking about. Consistent efficacy of saw palmetto has been suggested. Maybe some GI complaints, but notice the very last line there. Recent laboratory evaluation of 6 commercial brands of saw palmetto revealed the actual fatty acid content varied considerably. 3 brands contained less than 20% of the stated amount. So what are you buying? And it wasn't necessarily that it was poorly made. It might have just been a different area where it was grown, so where it was taken from. So St. John's wort, it does have efficacy. It's been around enough that people are comfortable enough saying that. It's used for depression. Let's see. It may be as effective as imipramine, which is a tricyclic, or an SSRI to treat mild to moderate depression. So, somewhat similar. It's been around long enough, it's been used enough where that one I feel comfortable about. Valerian, it's meant to be a sedative. There's something in that. The last one I always laugh at, Yohimbe. It's actually used to treat sexual dysfunction in men and in women, which I wasn't even aware of. But years ago, before we had Viagra at the VA, we had Yohimbe, and just the active compound. One day at the pharmacy, a husband and a wife came up, and the wife was just totally dominating the conversation. The poor husband couldn't say anything. And we were going down the list alphabetically, aspirin at the top, and then nifedipine in there somewhere. And finally we got down, and she kept saying what he wanted. We wouldn't let him talk. We finally got down to Yohimbe. I go, do you want more than the Yohimbe? And I thought, I hope they don't ask what this is for. And he finally looks up and goes, yes. At the end of the conversation. They walked away, she's going, honey, what is that for? So, but it could be a way of trying to increase sexual drive. But a lot of these herbs, you guys, is pretty overwhelming. You go to PubMed and look, but I still pull up this Sloan. You don't even have to remember that website. If you can just remember Sloan Kettering, herbal medicines, and Google it, you'll find that. And that is the best website that I've seen. When somebody says they're on this, just Google Sloan Kettering herbal medicines. Sloan Kettering is a famous Keenster Institute. Very well known. So, I'd like you guys to understand something about the laws around this. And it doesn't hurt to know that St. John's warts for depression and glucosamine chondroitin actually do work for joint disease. But other than that, understanding something about the principles of how these are made are very important. Because the players that keep changing here. Okay, so you don't need to know the herbal medicines. I do want you to know varenicline, though. So maybe I'll go back and just mark this. I'm not going to test you guys on the herbal medicines, on specifically. I won't ask, but probably herbal herbs, your information only. But looking at the varenicline, it's a new aid to smoking cessation. What does it do, you guys? You tell me. Read that there, that paragraph down there, and tell me what this drug does. Electrophysiology studies, in vitro. What is varenicline? Colonial-mimetic isn't a perfect description. Can we do any better? It's not wrong. Yes. Yeah, Kelly, that's what I was looking for. It's a partial agonist at nicotine receptors. Which kind of makes sense if we're trying to get somebody to withdraw from something to help them through the withdrawal period. This would make sense. It's a partial agonist at nicotinic receptors in the CNS. Yeah. So success rates with varenicline are about twice the placebo rate. It seems like a lot of these help smoking quit remedies that come out, they about double the placebo, and nobody seems to get above that. Placebo can be like 10%, and treatment with these drugs is 20%. One of the problems with varenicline, one of the side effects, it can just cause some psychiatric problems, some urges that you just have to be aware of. And let patients, if somebody's normally a very aggressive person, gets in bar fights and all that kind of stuff, probably not the best drug for them. Other routes that you can go, the nicotine gum, the nicotine patches. Bupropion is one of these, it's not a tricyclic antidepressant, but it was one of the kind of eclectic antidepressants. It also will about double the placebo rate. And, mechanism of action here can help somebody quit smoking. Nobody has any idea about that. Okay. One other thing before we conclude the pharmacology class. You guys, med school is so intense. Professors are under a lot of pressure. You guys are under a lot of pressure that sometimes I've had student comments come back at the end of the year and they say, gee, in some of his lectures, Dr. Zimmerman actually acted like he cared, unlike any of our other professors. It's like, wow. There's something wrong in the way we come across to you guys. So I just want to let you know. Now, there is a no alcohol policy on campuses, but I am not on the campus, you guys. So here's a glass of wine, and I just want to give you guys a toast. I hope you do well on your boards, and of course, I hope you finish up the course well. But good luck, and I'll be seeing you. We'll be making the final trip down there. Actually, there's 2 more trips. There's next week. Actually, I got a drink. But I'll come for the TBL, where we'll also do the student-directed learning, where you actually have to work on that question, you guys. We got to get that done. And then there's the biostatistics course. So, good luck, you guys, and I'll be seeing you.
What do you say?
Good night.
What's he doing, drinking? Yeah. He had a glass of wine. He's like, well, he was toasting us.